Today we're going to talk about Chapter 19, which discusses the cholinergic drugs. So when you hear the word cholinergic, you should predominantly think acetylcholine. Acetylcholine is one of the primary neurotransmitters in the autonomic nervous system, especially in the parasympathetic division. So any type of cholinergic drug is going to affect the activity at cholinergic synapses. Cholinergic stimulants are going to be agonists. They're going to evoke an action. So anything that's a cholinergic stimulus is going to, a stimulant is going to increase activity at any type of acetylcholine synapses. Remember, acetylcholine is the primary excitatory neurotransmitter of our muscle system, and it is only inhibitory at the heart. So for the most part, unless I specify acetylcholine in the heart, think excitatory. Acetylcholine is the neurotransmitter at the neuromuscular junction, really important for any type of muscle contraction and muscle movement. And the brain and specific areas of the brain contain cholinergic synapses and regulate cholinergic activity systemically as well. Some anticholinergic drugs have the capability to decrease the symptoms of diverse problems such as Parkinson's disease and motion sickness. So this is the opposite of cholinergic. So anticholinergic, remember on exam 2 we had a question about the anticholinergic side effects, which include the dry eyes, the dry mouth, the blurred vision, so on. So again, don't get anticholinergic confused with cholinergic. The cholinergic drugs have the capability to affect the synaptic activity by interacting with the acetylcholine receptor on the postsynaptic membrane. Really important, I want you to know where these drugs are working. They're working on the postsynaptic membrane. So this is after acetylcholine's been released from the presynaptic terminal, it goes into the synaptic cleft, and then it binds to the postsynaptic membrane. So this is where the cholinergic drugs are working. Really, really important. So at each particular cholinergic synapse, the postsynaptic receptors are responsible for recognizing the acetylcholine molecule and transducing the chemical into a postsynaptic response. We briefly discussed muscarinic and nicotinic receptors. What I really want you to know about these two receptors is that they both induce cholinergic activity. So the muscarinic cholinergic receptors, these are the ones that are going to be found on the peripheral tissues that are supplied by the parasympathetic postganglionic neurons. And these are what they're doing is they're basically supplying our effector organs, such as all the organs in the gastrointestinal tract, all the accessory organs that are associated with digestion, the urinary bladder, the heart, and the eye. The nicotinic receptors are the ones that are going to be located in the autonomic ganglia and in the SMJ. So depending on what drug you use, the drug could be selective or non-selective, and I'm going to give you a few examples of that as we go through this talk. So let's cover cholinergic stimulants. Again, I can interchange this and say cholinergic agonists. So we can have muscarinic agonists and we can have nicotinic agonists. These are both going to evoke a response that the receptor was intended to do. So any type, any type of cholinergic stimulant is going to increase activity at the acetylcholine synapses. And there are direct-acting and indirect-acting cholinergic stimulants. The direct-acting stimulants exert their effects by binding directly with the cholinergic receptor. Again, the cholinergic receptor is going to be found on the postsynaptic membrane. The indirect-acting cholinergic stimulants are going to increase synaptic activity by inhibiting an enzyme known as acetylcholinesterase at the cholinergic synapse. So again, this is really important, this mechanism here. I can derive a lot of test questions from this slide right here. So direct, it's acting at the postsynaptic membrane, and they're exerting their effects by binding directly with the cholinergic receptor at the postsynaptic membrane. The indirect acting stimulants, they're increasing the synaptic activity by inhibiting acetylcholinesterase. Anytime you hear the word esterase attached to the end of the word, anytime it's a suffix, that means it's breaking down the aforementioned molecule or compound or substance or whatever. So acetylcholinesterase breaks down acetylcholine, and this is working at the synapse, or the synaptic cleft between the presynaptic neuron and the postsynaptic membrane. Now let's dive a little bit deeper into the direct-acting cholinergic stimulants. These, again, are going to bind directly to the cholinergic receptor on the postsynaptic membrane, and their intention is to activate it and evoke a response. The direct-acting cholinergic stimulants may be considered true cholinergic agonists, and they function in a manner similar to how acetylcholine as a molecule functions. So once they bind to that receptor, they're going to initiate a cellular response. So you may think, why can't we just use exogenous acetylcholine in order to combat some of the diseases that have overactive acetylcholinesterase, such as myasthenia gravis? So generally what's happening, or one of the theories of what's happening in myasthenia gravis, is that there's overactivity of acetylcholinesterase at particular synaptic clefts, therefore it's breaking down acetylcholine, and that contributes to the peripheral muscle weakness that we see in patients with myasthenia gravis. Well, we can't use exogenous acetylcholine because it's degraded very rapidly and extensively by the acetylcholinesterase enzyme, which is found ubiquitously throughout the body. So what is the real difference between muscarinic and nicotinic agonists? Remember, I said that both of these can evoke a cholinergic response, so they're considered cholinergic agonists. Well, for the most part, drugs that have a greater specificity for the muscarinic cholinergic receptor are going to be more beneficial in treating a lot of pathologies. These muscarinic cholinergic stimulants will primarily affect the peripheral tissues, while exerting only a minimal effect on the cholinergic receptors located in the autonomic ganglia and at the neuromuscular junction. So if we're going to treat any major pathologies, especially myasthenia gravis, we're going to give something that is a muscarinic, a preferential or a selective muscarinic agonist, rather than a nicotinic agonist. So let's go through a couple of these drugs, and let's start with bethanechol. Bethanechol appears to stimulate muscarinic cholinergic receptors in the gastrointestinal system and the bladder. So I do want you to know that bethanechol is a direct-acting cholinergic agonist, and that it's used post-operatively for any type of GI issue and urinary atony. So urinary atony is lack of tone in the urinary system. Pilocarpine's the next one I want you to know. Pilocarpine's used to treat dry mouth that's associated with particular autoimmune disorders such as Sjogren's syndrome. So you should all remember Sjogren's syndrome from pathology. This is a disorder of your immune system, which is identified by its two most common symptoms, dry eyes and a dry mouth. So this symptom is one that accompanies many other type of immune disorders, such as rheumatoid arthritis and lupus as well. So a lot of times pilocarpine is going to be used in patients who are suffering from Sjogren's syndrome. It's also a main treatment in glaucoma. As far as the indirect acting go, I do want you to know ambinonium, because this is used to treat myasthenia gravis. I do want you to know the two drugs from exam 2 that we talked about for reversal of anesthesia blockade, edrophonium and neostigmine. Really important. We also can use edrophonium to treat myasthenia gravis. And neostigmine is also used to treat myasthenia gravis. But remember from exam 2, the question that I asked about these two particular drugs it was a question asking which drug would be useful in reversing the anesthesia blockade. So remember, when we give intravenous anesthesia, there's going to be rapid onset of the effect of the drug. The bad thing about injecting intravenous anesthesia is that we don't have relative control over the drug per se. That's why the anesthesiologist has to be present in all the surgeries, because if we give too much IV anesthesia, the patient can go into stage 4 anesthesia, which is medullary paralysis, and that would be very bad. So again, I want you to know bethanechol, pilocarpine, edrophonium, neostigmine. I also want you to know donepezil. We're going to talk about donepezil. For now, just know that it's associated in one of the drug cocktails to treat Alzheimer's type dementia. We're going to dive into more of that. So kind of keep donepezil, rivastigmine, and tacrine in the back of your mind to help treat the Alzheimer type dementia. Now let's move into the indirect acting cholinergic stimulants. So remember, acetylcholinesterase, this is the enzyme that's responsible for destroying acetylcholine after it's released from the presynaptic terminal. So how these drugs work is they increase the activity at the cholinergic synapses by inhibiting the enzyme that's breaking down acetylcholine. The indirect acting cholinergic stimulants inhibit acetylcholinesterase. So it allows for more acetylcholine to be present in the synaptic cleft, therefore hopefully more can bind to the postsynaptic membrane and the response can be transmitted downstream. So all of the indirect acting cholinergic stimulants tend to inhibit acetylcholinesterase found at many of the cholinergic synapses. They do have a potential to exert a stimulatory effect on the peripheral muscarinic cholinergic synapses and on the cholinergic synapses found at the autonomic ganglia. They can also work at the skeletal neuromuscular junction, and they have the potential to work within certain aspects of the central nervous system. The unfortunate aspect about the indirect acting, as the name implies, they lack receptor specificity. So they can bind to the muscarinic receptors, therefore they're not the gold standard line of treatment if we want to attack and if we want to aid acetylcholine transmission. We're usually going to give a direct acting first. If the direct acting is not working, we'll go to the indirect acting. Again, tacrine and donepezil, they're used in Alzheimer's disease to potentially slow the dementia and the progression of the dementia. Both tacrine and donepezil are more specific for cholinergic synapses in certain regions of the brain that are associated with Alzheimer's disease, and that's why they're being used to boost cholinergic function in neurodegenerative disease. So now let's talk about the clinical applications of the cholinergic stimulants. So Alzheimer's disease, for those of you that don't know what it is, it's essentially a neuronal degeneration of the cholinergic neurons that are really critical for memory function, just general cognition, and other higher cortical functions that we take for granted on a daily basis. And what the drugs do, these cholinergic stimulants such as tacrine, donepezil, galantamine, and rivastigmine, how they aid in stopping the progression of the dementia associated with Alzheimer's disease, they inhibit the acetylcholine breakdown in these particular brain areas, and these drugs have the capability or allow for acetylcholine's action to be prolonged, and then therefore acetylcholine is essentially going to be spared from degradation, and it can be released from the neurons that are still functioning in the cerebral cortex. There is a lot of discrepancy and a lot of mixed literature on these drugs. Some papers are saying that these drugs don't help in the progression of dementia or don't help in inhibiting the progression of dementia. But I do want you to know that tacrine, donepezil, galantamine, rivastigmine, that's what they're used for, although the literature is very mixed right now. They don't alter the progression of Alzheimer's disease itself, okay? So they're not, they're not working on any of the degeneration that's occurring in the particular brain areas, but they do have a tendency, there's some studies that show that they are slowing the dementia progression. So really important concept to know. They're not working on neurodegeneration. So they're not working on sparing any neurons that are undergoing neurodegeneration. They're not making the brain areas come back or anything like that. All they're doing is the neurons that are still functioning, they're working on those particular neurons to allow them to release more acetylcholine and therefore slow the progression of the dementia. They're not going to stop the progression, they're only going to slow the progression of the dementia, not the disease itself. So, and as the disease progresses, all of these drugs tend to lose their effectiveness. So long term, they're not really useful in my opinion. Any type of GI issue and urinary bladder atony, that's going to be treated with bethanechol and neostigmine, as I mentioned. What else? Glaucoma. So for those of you, wait, let's go back to the GI complications real quick. A lot of patients who are suffering from inhibition of intestinal peristalsis. So what's happening is the contents that are within the GI tract after eating are not moving very good, or due to this intestinal peristaltic inhibition, what these drugs do is they help to mobilize the bolus of food and they help move the contents along the GI tract. They also work in the urinary bladder atony to help with urinary retention. So they will help facilitate urination essentially. So glaucoma is an increase in intraocular pressure brought on by the accumulation of aqueous humor within the eye. So when you get this accumulation of aqueous humor, not only can it lead to blindness, but it can cause a lot of cognitive issues, especially headache. So the pain can overwhelm a patient at some time, and the patient may have just a general decreased quality of life because of the massive amount of pain the patient's in. So normally cholinergic stimulation occurs via the parasympathetic supply to the eye. And this allows for the increase of the outflow of the aqueous humor. And that's what actually prevents the excessive accumulation. So if we're having some type of decreased cholinergic stimulation or decreased cholinergic activity, that aqueous humor is going to accumulate. And if it accumulates too much, again, it can result in impaired vision and blindness. So that's why we use cholinergic stimulant drugs in glaucoma, so that we increase the outflow of the aqueous humor to prevent any type of excessive accumulation. So that's why it's used to treat glaucoma. The drugs there for myasthenia gravis are listed again. Again, myasthenia gravis is characterized by skeletal muscle weakness in the periphery. There's demyelination of the Schwann cells in the periphery, so a lot of patients will exhibit peripheral muscle weakness. One thing that's really concerning about myasthenia gravis is the cholinergic response in the respiratory system. So eventually, if myasthenia gravis progresses and becomes very severe, the respiratory system can shut down, and therefore the patient will stop breathing. So it's a very concerning peripheral demyelination disease. We don't really understand all the pathology of it at this point. There are several theories. The main theory is that there's overactivity of acetylcholinesterase at the synaptic cleft, and thereby giving cholinergic stimulants, hopefully we can allow for acetylcholine transmission to be elicited from the presynaptic neuron to the postsynaptic neuron and elicit acetylcholine's desired response. So again, those are some major concerns with myasthenia gravis. Again, I do want you to know, and this will be another test question, about edrophonium and neostigmine, how they have the capability to reverse the neuromuscular blockade that's associated with anesthesia. And the cholinergic stimulants, as the name implies, they have the capability to reverse any type of anticholinergic induced central nervous system toxicity. So just like any drug that we put into the body, there are going to be problems and adverse effects. So again, I talked about the lack of specificity of particular receptors with these cholinergic stimulants, so they may stimulate muscarinic receptors on different tissues. That's pretty much the extent that I want you to know. Don't worry about the muscarinic effects that it's evoking. Just know that it can stimulate these muscarinic receptors. Ideally, we want to go to particular muscarinic receptors. There's actually M1 through 5, and different muscarinic receptors are geared towards doing different tasks. So I'm not going to ask, what particular muscarinic receptor is neostigmine versus pyridostigmine versus edrophonium binding to. Just know that they lack specificity at certain times. The cholinesterase inhibitors may increase synaptic activity at all the synapses. So this could be potentially bad because we could get muscle firing that we don't want to have firing, and it could lead to muscle spasticity and muscle spasms. Again, the other side effects are listed here on the slide for you. You see these with a lot of drugs: nausea, vomiting, diarrhea, increased salivation, bronchoconstriction, bradycardia, difficulty in visual accommodation, and diaphoresis, which again is excessive sweating. So these are the effects of the cholinergic stimulants. I highly recommend you to make a list of the side effects or adverse effects of the cholinergic stimulants and keep these separate from the anticholinergic side effects that you have already learned. Now we're going to switch gears and talk about the anticholinergic drugs. The purpose of the anticholinergic drugs are to attempt to diminish the response of tissues to cholinergic stimulation. So if we're getting some type of overactive tissue due to cholinergic stimulation, you're going to give an anticholinergic drug. Really important concept right here to know. These are competitive antagonists of the postsynaptic cholinergic receptors. Remember, the cholinergic drugs are going to elicit their effect at the postsynaptic membrane of the cholinergic receptors. So these anticholinergic drugs, they're competitive antagonists at the postsynaptic cholinergic receptors. They bind reversibly to these receptors, so therefore they can fall off. Remember from the differentiation between the competitive antagonists versus the non-competitive antagonists. Competitive antagonists, whatever drug is at a higher concentration at the receptor, that drug is going to predominate the effect. So this is the example that I gave you about the competition between naloxone and heroin. We use naloxone to reduce the potency of heroin. So the more naloxone you give, because it's binding to that same mu-opioid receptor, it's going to have a tendency to preoccupy that receptor. But again, once the naloxone wears off in the body, it's going to dissociate from the receptor. So same principle here. Anticholinergic drugs are competitive antagonists of the postsynaptic cholinergic receptors. So again, they're going to bind reversibly. They're going to block that receptor. They're not activating the receptor. All they're doing is occupying and blocking the receptor. Two really important drugs I want you to know: mecamylamine, M-E-C-A-M-Y-L-A-M-I-N-E, and trimethophan, T-R-I-M-E-T-H-A-P-H-A-N. These are both anti-nicotinic drugs that are used to treat high blood pressure and hypertensive emergencies. And many other different types of anti-nicotinic drugs are used to block the neuromuscular junction to produce skeletal muscle paralysis during surgery. And we'll talk about that in a couple of slides. Now we're going to talk about the source and mechanism of action of the antimuscarinic and anticholinergic drugs. So we'll talk about atropine. Atropine is one of the drugs that's usually seen on the crash cart in the emergency setting. Atropine has the capability to reverse the effects of excessive vagal charge and is used to treat bradycardia that may accompany myocardial infarction. Atropine can also be used to alleviate urinary frequency and incontinence caused by hypertonicity of the urinary bladder. Many of you may have went for ophthalmologic exam, so getting an eye exam, either for glasses or for LASIK surgery or for contact fitting, whatever. Atropine is the drug that's going to be used during that exam to dilate the eye. This is the prototypical antimuscarinic, anticholinergic drug. This is actually is derived from several different plants. Atropine is found in the wild, especially in plants known as belladonna and jimsonweed. You don't need to know those. That's just some plant knowledge for the day. However, there are muscarinics that preferentially affect some tissues more than others. Some preferentially antagonize the gastrointestinal muscarinic receptors, whereas others have a predominant effect on the central nervous system cholinergic synapses. Virtually every antimuscarinic drug will have the capability to antagonize cholinergic receptors on a number of different tissues. And again, the antimuscarinic drugs have the capability to bind to many different muscarinic receptors. Again, I mentioned this previously. There are M1 through M5. This is just for your general knowledge. You don't need to know what particular receptor, which drug's binding to. But atropine, the main mechanism of action, I want you to know, it has the capability to block the postsynaptic cholinergic muscarinic receptor. So the anticholinergic drugs can be used to treat GI disorders such as peptic ulcers, irritable bowel syndrome, neurogenic bladder, bronchospasm, and the list goes on and on. I do want you to know that atropine is used to treat all these, and atropine is used to treat the bradycardia that's associated with MI. Any type of stimulation of the gastrointestinal tract via the parasympathetic cholinergic neurons generally produces an increase in gastric secretions and an increase in gastric motility. So that's why we're going to give some type of anticholinergic drug. That's why atropine is so effective in peptic ulcer disease and irritable bowel syndrome. Remember, from pathology, irritable bowel syndrome, or IBS, is characterized by hyperactivity of the gastrointestinal smooth muscle, and it includes problems such as irritable colon and spastic colon. The antimuscarinic agents are sometimes referred to as antispasmodics because of their ability to decrease gastrointestinal smooth muscle tone or any of the spasms that are occurring in the gastrointestinal tract. So atropine is really important. Let's move into talk a little bit about Parkinson's disease. Parkinson's disease is characterized by, it's a movement disorder. Remember, I gave you the mnemonic TRAP. The T stands for tremor, the R stands for rigidity, the A stands for akinesia, and the P stands for postural instability. So the Parkinsonian movement disorder is characterized by a deficiency of dopamine in the basal ganglia. And then what happens in Parkinson's disease is this deficiency of dopamine in the basal ganglia leads to an overactivity of central cholinergic synapses. So drugs such as benztropine, biparidine, and trihexylphenadiol are used because they preferentially block the central muscarinic cholinergic synapses involved in Parkinson's disease. So some of the side effects, again, the anticholinergic side effects, the dry mouth, the dry eyes, the constipation, the urinary intention, and these are all caused because of their antagonistic effect on the muscarinic receptors that are located outside of the brain. So I do want you to know all those drugs I just mentioned. I also want you to know methscopolamine and scopolamine. Scopolamine, well, let's start with methscopolamine. I just want you to know the general function that it's used to treat peptic ulcer disease. And then a scopolamine, this is actually isolated from the angel trumpet, or Toei. This has the capability to block cholinergic transmission from areas of the brain and brainstem that mediate motion-related nausea and vomiting. So scopolamine is going to be given to prevent motion sickness, and also is a great antiemetic that is used after surgery happens. So it's a post-operative nausea and vomiting inhibitor after surgery. So again, I want you to keep the side effects of the anticholinergics and the cholinergic stimulants separate. So this should sound very familiar to you. This was a question on test 2. This will be a question on test 3, and it will be a question on your final exam. So I highly suggest for you to know this material. The anticholinergics produce dry mouth, dry eyes, which can result in blurred vision, urinary retention, constipation, and tachycardia. Some patients also report symptoms such as confusion, dizziness, nervousness, and drowsiness. And we think that this is because there is some type of interaction between the antimuscarinic drugs with the central nervous system cholinergic receptors. These central nervous system related symptoms occur more frequently with anticholinergic drugs that have the potential to readily cross the blood-brain barrier. So this question here is the first of the 8 questions for the interactive learning assignment. I want you to read this question and answer it and give rationale and cite where it came from in your textbook. Same thing for this question. This is the second of the 8 questions that are going to be used for your interactive learning assignment. Please answer this, use logic, and please use proper citation.